Live from the Washington, D.C. area, it's the Inside Scoop. All the news that our viewers want to know. Now, here's the host.
I'm your host, Melissa Batchelor-Murphy, and we're continuing our healthcare series. And tonight we're going to be talking about advanced care planning. And advanced care planning can deal with healthcare issues, financial issues, and/or legal issues. But tonight we're mostly going to focus on the healthcare issues and the legal issues. I'm joined in the studio tonight by Dr. Lynne Kennedy, who is the Clinical Director of Palliative Care for the Inova Health System.
Yes.
And you have you're a nurse with a PhD.
Yes.
And then you have some other letters, so tell me what those mean.
I'm a certified palliative care hospice nurse, and I'm also a certified healing touch provider.
Well, thank you very much for being with me this evening. So maybe you can tell me a little bit about yourself and how you got interested in palliative care?
Well, it really goes way back. Hospice was first started in North America in Connecticut in 1975. And about a year later, the word palliative care was first started in North America in Montreal at McGill University. And I did my nursing training at one of the 5 hospitals that belonged to McGill University. And palliative was something that interested me right away. And I really wanted to get involved in it, not in the hospice section, because I really liked hospital care. I liked being able to give that more intensive care to people who were in a crisis or who were very ill. And it took a very long time. It's all the way back to the 1970s. It's taken up until very recently for palliative care to begin to be understood.
So we'll start there then. Mm-hmm. Why don't you explain to viewers what palliative care means and how it's similar and or different than hospice?
Well, it's easier to say what palliative care is not than what it is. It's not giving up on a patient. It's not giving up on curative therapy. And it's definitely not the same as hospice. It's not end-of-life care. Palliative care should be started as early as the diagnosis of a serious, life-limiting illness during the curative phases to help people with psychosocial support and with spiritual support when they're going through a very personal crisis. They have a lot of fears. They have a diagnosis that they did not expect. They're being treated, and the treatments have a very high symptom burden, and they need those things taken care of as well. So that's where we come in. And we do treat pain. We treat all of the symptoms that come with being ill, but we also help people begin to express themselves and dig down deep within themselves to bring up what's important to them now, what are their fears, what do they want to communicate to their families, how do they want to communicate this. And we begin delving into what they know and what they don't want to know and what they do want to know, and taking them down that road, which will change as their illness progresses or leads to cure.
So my understanding right now of palliative care is that it is mostly delivered in hospital settings or nursing homes. Yes. And I can remember, in 2000 when I became a nurse practitioner, most of my job was palliative care. And now it's beginning to move into the community. So where do you kind of see the intersection of those different settings?
Well, I see it becoming a continuous process where, in the same way that our patients eventually may go to hospice care, those same companies are now providing palliative care, and they are our partners in the community, so that we bring them in, and the patient's not transitioning to hospice but still needs that palliative support. they take over the care, and they can do it at home. They can do it in nursing homes. They can do it in assisted living facilities. Wherever that patient is home. And they need to be cared for in that setting, and they need to be comfortable.
So when you say that we can do palliative care, what
Yes.
are some of the key things that you do? I heard you mention pain management as one.
We do all kinds of symptom management based on the type of curative therapy that they're going through. Sometimes it's just pain. A lot of times it's anxiety, agitation, particularly with patients who are progressing in dementia. Agitation seems to go right along with it because they begin to forget things, and they know that they're forgetting something, and they become very agitated about it. So we help them with that. We talk them through their fears. We talk them through what they're experiencing. And we also use alternate therapies like healing touch and like Reiki that a lot of people have heard about, that really work very well in reducing the need for medications and truly improve the way people feel and can communicate. They can be calm, and suddenly they can eat again because they're not all burdened up with this terrible anxiety. And they can just relax. They can take less opioids. Now, we all want to take less opioids if that's possible, but with alternate therapies, frequently you can really reduce the amount of pain medications that you're taking as well. It helps with dyspnea, which is difficulty breathing. So if somebody has shortness of breath because either they're anxious or because of their disease process, it will help them. So it doesn't have to be just medicine, and it doesn't just have to be talking. Sometimes we can do other things and incorporate in with that the ability to learn a little bit about meditation so that they can calm themselves, to do some yoga if they're physically able to, because exercise helps to beat the fatigue with cancer patients. If they can exercise, they can actually get over that barrier and have more energy. So we encourage all kinds of relaxation therapies.
And I think another thing I hear you saying is it's not necessarily one-stop shopping. That,
Right.
you know, this trajectory from the moment you're diagnosed with a life-limiting illness all the way through end of life, that you're kind of adjusting care.
Yes, absolutely. It needs to change, and our patients tell us when when we talked about, I think it's time to do that now. Let's change the way we're addressing this. I don't want to be sleepy all the time. I would like to make a change to my daily routine. I don't know why suddenly I'm having a lot of pain, so much pain that I can't eat, but I don't want to take more medication. And sometimes it's as simple as they're living in a 3-story townhouse and they're doing all of this getting ready, coming down the stairs, and they're in excruciating pain. And sometimes it's as simple as saying, well, why don't you set your alarm and you take a pill and then watch the morning news on TV for 15 minutes, then take your shower and come downstairs. And suddenly, I hardly had to take any medication yesterday. I was able to eat because you're thinking through what it is you're doing.
Yeah, it sounds like a lot of problem solving, but very highly individualized.
There are no
problem
two
solving.
people that are the same.
Which is what I actually love about geriatrics and palliative care. Is
Yes.
that you never know what you're going to get. You know.
Yes, and it's amazing how much people realize about themselves as you begin to delve into what's going on in their lives at the moment. Oh, I can't tell my daughter this because it'll make her sad. And the daughter will come to me, oh, don't tell mom that she's really sick. She's going to make her die faster. And of course, that isn't true.
Right. I mean, just because we talk about end of life doesn't mean that it's going to happen
Right.
as soon as you're done with the conversation. But it is one thing that all of us are going to have to go through. And I think the most important thing that palliative care brings to the table is it gives you time, if you're given the gift of time, to plan, just like you would spend time planning for a birth, planning for a wedding. You know, I've always told people I was a really good death planner.
Yeah. Well, in North America at least, what has happened is we've medicalized death. We've denied it. Well, it's inevitable. It's going to happen to all of us. And we all have a picture in our head of what that should look like, but we don't want to talk about it. And sometimes that's ethnic or cultural, and that's fine. We understand that, and we do not tread on people's cultural beliefs. These are very important to them, and we understand that, and we try and learn as much as we can about everybody's culture. But in North America, we're in a sense of denial. We have all these machines and all of these drugs and all of these treatments, and I'm just going to keep on going.
Right. Well, the perception, I think we were talking before the show, and people say, I want everything done. But sometimes everything, once you hear what everything is, you're like, oh, I didn't really mean everything. My everything was here.
Yeah.
You know, and so I think part of what palliative care can do is help people have that conversation and see the options.
Yes, and that's most of what we do, is we talk to people about the options and how they will affect them in their personal trajectory, in their personal life, depending on what's going on with them from an illness perspective and from an aging perspective. Because something as simple as having intravenous therapy can have a very different result on somebody with cancer than somebody who's at end-stage coronary heart failure. Very different. It's no longer something simple. And having multiple chances at antibiotics can actually lead to more diseases, as we know with MRSA.
Yes. Well, drug-resistant antibiotic types of conditions.
Yes.
So we will come back and continue talking about the differences in hospice and palliative care. And you can see this and others at melissabphd.com.
You know what, guys? There's a lot of tree branches and dry brush over here. We should probably move the bonfire over there.
I'm guessing Smokey liked that idea.
Hey, Hard, what's this?
That's my resignation.
You're resigning.
Why?
You've been putting me under a lot of pressure lately. That's why I'm ready to quit.
Oh, I forgot. I'll do better. Please don't quit on me.
Don't let your heart quit on you. Get your uncontrolled high blood pressure to a healthy range before it's too late.
So you can't save money? That's easy as pie. Brown bagging lunch instead of going out. $6 save times 5 days a week times 10 years is $21,000. That's a lot of lettuce. Small changes today, big bucks tomorrow. Feedthepig.org.
Did you know kids who play outdoors have healthier lungs?
Totally.
I did. Did you know that boys that play with dolls make better husbands?
My son has lots of dolls. But did you know terry cloth diapers breathe better?
I did.
It's totally true.
Oh, yeah.
Did you know that strollers have the right of way on the sidewalk?
Yes.
Yep, I did. Did you guys
Did you know that kids who eat breakfast have higher GPAs?
Yeah, I know.
Yeah. That's actually what I was going to say.
Did you know babies should never touch silver? It's really bad for them.
I knew that.
Did you guys know that statistically friendly kids have more friends?
Yeah.
That's obvious.
Did you know most people think they're using the right car seat for their kid, but they're not?
Parents who really know it all know for sure that their child is in the right seat at the right age and size. Visit safercar.gov/the right seat to make sure your child is protected.
I'm putting that on my blog.
I just put it in mine.
we're back to the Inside Scoop. Here again, your host.
Welcome back to the Inside Scoop, and I'm your host, Melissa Batchelor-Murphy, and we're continuing our healthcare series, and tonight we're talking about advanced care planning and hospice and palliative care. And I'm joined by Dr. Kennedy. And so earlier we were talking about when should people begin to think about palliative care? And I think the biggest problem is consumers don't know that palliative care exists. I think most people do understand that hospice exists. But what are some of the kind of life-limiting illnesses or things that would trigger someone knowing it was time?
Mm-hmm. Well, sometimes they are illnesses that are progressive, and you don't really think of them as a life-limiting illness, like COPD, which is one of the most frequent diseases of men over 55. And they don't really think of it that way. They're just having a little bit of trouble catching their breath. Mm-hmm. But it is a life-limiting illness, and they need to think about that. And then you get into all types of heart disease and coronary disease.
Which is the #1 leading cause of death.
Absolutely. Absolutely. When I first began talking to people about life-limiting illness, they were thinking cancer. That's the only thing that they were thinking. Mm-hmm. They weren't thinking about dementia, but when you're diagnosed with dementia, you need to start thinking about what the end is going to look like, what the trajectory is going to look like, and how you're going to live the rest of your life. Mm-hmm. Because it is a life-limiting illness. There are a lot of people that don't realize that. They just think that it just progresses along its way and something else happens.
Which could be true. You can either die from Alzheimer's or you'll die with it.
Right. But if you had nothing else wrong but dementia, it would still eventually kill you.
Right. And typically that life expectancy is about 10 to 15 years max.
Yes.
So it is important at the beginning of that, anytime these diagnoses are made, that's when the conversation needs to happen.
Yes. And the same thing with stroke. A lot of our patients in the hospital are stroke patients who never thought of themselves as palliative patients. They're recovering, they're getting better, but they need to start thinking about how life has now changed, even if they're totally recovered from the stroke. Mm-hmm. Because it has changed. They need to be taking medication, they need to eat properly, they need to watch their fat consumption, they need to watch their diet. All of it is part of invoking your palliative option. Has nothing to do with hospice at this point.
Right, and so we've talked about, I think around the mid-1990s is really when palliative care kind of took hold, and mm-hmm. in 2015 the Institute of Medicine produced a book called Dying in America.
Yes.
And it's a book that's freely available online that you can read through, and it really kind of discusses kind of the state of affairs of dying in America. Mm-hmm. And what we're doing really well and what we need to do better. But what do you think some different barriers are to palliative care kind of breaking through to where everybody knows it and understands it like they do hospice?
Well, one of the biggest barriers is that everybody associates palliative care with hospice. And I understand that because all of hospice is palliative care. But palliative care outside of hospice is a great deal more. Another part of the problem is that physicians in their offices have not normalized the process of talking about just planning for what your life should look like. What are your goals of care? What's important to you now? They don't take time out because they don't really have time. They need to see the next patient and the next patient. Or they're afraid that their patients will think they're being deserted because you're sending me to a palliative care doctor? But does that mean I'm giving up? But of course they're not giving up. They're going to get a whole range of support that they never had before.
And so another big distinction between hospice and palliative care is that hospice truly is meant to be something if you have 6 months or less left. And so then that becomes very kind of immediate, end of life, kind of more imminent. And what you're saying, like for palliative care, you could start 10 years prior to somebody reaching that point.
Absolutely. And the strange part is that even though hospice is meant to be the last 6 months of life, people do not get referred into hospice until the last 11 to 10 days. Yeah. So they lose the benefit of that. You don't have to be bedridden and hospitalized and in excruciating pain to go into hospice. Hospice patients go to the beach, they go on cruises, but they have other support and they understand what's going on with them and how they should handle their illness. There's a lot of support within hospice.
Mm-hmm. And a lot of that same support are things that you've mentioned.
Absolutely. And there's even more support within palliative because that starts the learning curve. It starts identifying people's own needs, and everybody's needs are different. Regardless if everybody in the room had the same illness, they would all have different needs around that same illness.
True. And actually the latest Health Affairs art journal, the month of July, was dedicated towards palliative care, and there's been a call now to try to create some type of national plan to kind of address the fact that we need more people trained in palliative care. So it sounds like you were a very early adopter with your training. So how long have those certifications and things kind of been around, and how did that help improve your practice?
Well, the certifications have been around, I would imagine, about 15 years. But most people did not pursue them. I was very lucky in the Inova health system, where administration throughout the system was very supportive of developing a center of excellence at one of our hospitals. And we built a wonderful team of providers and clinicians, and we give wonderful care to patients. And we've been recertified twice already. And I've gone through the other hospitals within our system. We have a totally different model at our flagship hospital, where all of the providers are employed by the hospital, but the same type of team, which includes therapists, social workers, and chaplains, and specially trained nurses, and specially trained nurse practitioners and physicians, and we work together as teams.
Right. I think one of the things that you've mentioned is kind of individualizing, but what you just kind of laid out was you have your medical perspective, the social perspective, the spiritual perspective, and then kind of the emotional parts. And so I really think that those are really all the things that palliative care helps families with, because most of what we've talked about has been the patient, but anybody that we're dealing with, there's always two of them. There's the family member, and then there's the patient.
Right. And we encourage the family members to get more involved with the patients. And this helps down the road so that people aren't fighting within a family about what mom really wanted.
Right.
Or what dad really wants. And he doesn't understand what he said he wanted. He really wanted this. But he understood, and they need to know that right up front. They need to understand why he's making the decisions, and why she wants this type of care and he wants a different type of care. And a lot of it also depends on their personal experiences that they have. They might have seen somebody with that same illness in their family who went through an excruciating time and was not well cared for, and they think that that's what they're facing. And they need to know that's not the case anymore.
Right. Well, and the other part of it is everybody's going to have a different story because it's just like no two mothers have the same birth story.
Right.
No two families have the same end of life story. But I think that giving someone the opportunity for a high quality end of life is really where palliative care and Inova, you really are leaders in this. One of the articles in that Health Affairs Journal talked about how the South is lower than the national average for available palliative care services. So kudos to you guys for starting early.
Well, we've got good teams in all of our hospitals now, and I think that we're benefiting the community that way. But we're also teaching physicians, because they can have the conversation. It should really start in their offices. In a normal situation, when somebody isn't really ill, but identify the things that are important to them.
Right, and that's really the start of the conversation. Hey, Mom, hey, Dad, let's talk about what's really important to you. I want to hear it from you.
Yes.
And I know in my own work, it was much easier to tell people, I don't need you to make the decision. What I need for you to do is tell me what decision you think your parent or your loved one would make.
Have made, exactly. And sometimes that's the only way to stop a discordant family from fighting with each other across the bed of their parent. Picture your mom standing at the end of the bed and looking at this, and what would she say about it?
Yeah, and they typically know, like,
yes, and all of a sudden they have the answer. And I said, well, isn't that what we should be deciding? And all of a sudden, it's like the light bulb goes on. It's not about me, it's about her.
Which really does help families with these
But
things.
if they only started having this conversation years before that, if people talk to each other. I know when I discussed it with my family, it was over Thanksgiving dinner. And we always go around the table and try to decide, well, why are we blessed this year? What's good about this year? And Dad and I are giving you a gift, because that's what it is when you discuss it. We're giving you a gift. You don't have to worry about the kind of care you're going to have to decide for us. We're telling you what we want.
Yes. So when we come back, we'll talk with Rebecca Geller about some of the legal issues with care planning. And then our fourth segment, we'll give you some tips and strategies for actually how to begin to have these conversations with your loved ones. Thank you very much.
Strawberries? Okay.
Okay, so what would you bring to my company?
What do you need?
I need problem-solving skills.
I got through high school without a car, a phone, or a computer.
No college degree, though.
Not yet, but life's taught me a lot, and I'm ready for more.
Well, you're not the typical kind of candidate that I hire. But you are exactly what I'm looking for.
Your company could be missing out on the candidates it needs most. Learn how to find a great pool of untapped talent at gradsoflife.org.
They'll test you. Try to break your will. But however loud the loudness gets, however many cheese puffs may fly, you're the driver, the one in control. Stand firm. Just wait. And move only when you hear the click that says they're buckled in for the drive. Never give up till they buckle up.
Live from the Washington, D.C. area, it's the Inside Scoop. All the news that our viewers want to know. Now, here's the host.
This evening we're going to be talking about advanced care planning, and there are legal aspects to that as well as care planning that you need to do with your medical provider. So right now I'm joined by Rebecca Geller from the Geller Law Group, and maybe you can just begin, I think probably one of the hardest things for families is actually beginning to have this conversation about how we want the end of our life to look. So maybe you have some strategies for how to get the conversation started, and then what are the main things that we need to have in place to help our loved ones.
Absolutely. Well, first, thank you for having me. I'm excited to be here today. This is a hard conversation. It's something nobody ever really wants to think about, but it's one of those things that people, when they deal with it, they say to me afterwards that they have peace of mind to know it's taken care of and they don't have to worry about it. So how do we start this conversation? And usually what I say to people is that if you're having this conversation with a loved one, especially if it's an adult child having a conversation with a parent who's older, is to start by saying, I want to have this conversation because I want to be able to take care of you. The way you took care of me when I was a child, I want to make sure I can take care of you. And some people shy away from this topic because they think it seems greedy to talk about wills and trusts and medical directives. But the reality is you have the conversation and say, Mom and Dad, I want to inherit nothing from you. Live your life, travel, enjoy your life. I'm not looking for money here. I want to make sure we have legal documents set up so that I can take care of you as well as that you can take care of each other, especially as people age, that we have issues like dementia or Alzheimer's. One of the hardest conversations I have with my clients is when somebody comes to me and says, my mom is starting to experience dementia. I'd like to get an advanced medical directive put into place so that I can be able to make medical decisions for my mom. At that point, it's very hard to do because we have to have a medical determination from a doctor specifying, does this person have the mental capacity to be able to enter into a legal agreement? If I have a client right now who, she's in a nursing facility, she's in her 60s, she doesn't even know what day of the week it is or who the president is. And, in that kind of a scenario, does she have the legal capacity to sign something saying that she gives her adult child the ability to make medical decisions? Not really. And so then we have to go through the courts. So we want to prevent all of that. The best time to create these documents is when people are relatively young and have able a mind, and they can enter into a legal document so that they know, no matter what happens, somebody will be there to take care of me, or for the adult child, I can take care of my parent as well.
Right, and we usually tell people, especially if you're in a primary care situation and we begin to see that somebody's having some memory problems, we say if you don't have your advanced directives in place right now, you need to take care of that. So that is a big thing. So if you if you're not facing kind of a terminal illness type thing, at what age would you recommend that people begin thinking about this?
18. I joke, but the reality is once somebody becomes a legal adult, you need to start thinking about this. And we look at this from a multi-generational perspective. If you are an adult, to look at it as far as the adult taking care of each other or taking care of yourself. So, for example, if you are a single person, you're not married, or you're divorced or widowed or whatever, if you're in a car accident, who's going to be able to make medical decisions for you if you can't make them for yourself? We never know when things are going to happen. So it's not just planning for when we're older, but it's really any time in our life. I was in a car accident last year, and who can make decisions for me if I can't make them for myself? I have a client who is an ER physician, and he says he wishes every single person who came through his ER doors had this document already. Now, when you go to a hospital, hospitals do have these kinds of very boilerplate template documents that they'll have you fill out. out. Usually they're pretty terrible, and it's really not a nuanced document. A lot of times people say, you know, this is pretty simple, and then we look into the details. This is not an area that's black and white. Most of my clients want there to be shades of gray. Do you want to be kept alive on life support? And if you were in a persistent vegetative state. For most of my clients, it's not a yes or no answer. It's a, you know, yes, I would want to be kept alive on life support until my loved ones could come say goodbye, or for a certain period of time. Questions about organ donation, blood transfusion, risky procedures, you know, especially with medical technology. What is it you would want, and who do you want making the decisions for you? Even if you're married, you still want to have this in place. What if you're in a car accident with your spouse and neither one of you can make these decisions? Who's the next person in line? Is it an adult child? Is it a sibling? Is it a best friend? We usually have lists of kind of alternates that we have there.
And this is a living will that you're talking about, or like a medical power of attorney? I mean, are there different types of documents? So what you're just referring to, that's more of the living will?
So living will is kind of a colloquial term. In Virginia, the legal term is the Advanced Medical Directive, and that handles all things dealing with medical. But you did bring up another point that I want to touch on, is that medical directives are just for medical decisions. The legal on financial decisions is entirely separate, and that's actually a separate document that people want to have a lawyer create for them. It's called a power of attorney. A power of attorney handles things that are legal and financial related. So let's say you're in the hospital, and who's going to sign authorizing your health insurance company to pay your medical bills? If people are under anesthesia or in a coma, who's going to pay your credit card or pay your mortgage? Even for married couples, a lot of married couples mistakenly believe, they think, oh, well, we're married, we have a legal right to sign for each other. Now, that's true if you have a joint bank account or a joint mortgage, then yes, of course you do. But every single married couple that I've ever worked with have things that are separate. Right. Most people have separate credit cards or life insurance policies or retirement accounts. You know, without this kind of a document, you don't have the ability to handle things for each other. And who's beyond the two of you? Who do you want beyond your spouse? Especially if you're not married, this is even more important. But really, everybody should have this.
Okay. So, and I will have two thoughts in my head. One is around, you know, purposefully keeping things vague, and I think that that's an important point because you cannot possibly predict all the different variables that are going to have to go into making that decision. And then the second part is, where should people keep these things?
So I would say actually not as vague, but more broad. Kind of having broad strokes. You know, for example, with the power of attorney for legal and financial decisions, there's things in there now that we would never have seen 10 years ago. Digital accounts, social media accounts. If you're under anesthesia or in a coma or have dementia, who do you authorize to handle your online footprint? We didn't have that 10 years ago. So if you're somebody who created their power of attorney 10 years ago, it probably didn't have that. If you own a business, just because you're married does not mean that your spouse has the ability to handle things for you. I have a client right now who has a construction company, and I just got a call from the brother who is trying to figure out, well, what do I do with the business? Because my brother's now on life support, and you know, there was no power of attorney. So if he had a power of attorney saying, I designate somebody to be able just to wrap up my business for me, we want to have that. So having it pretty broad of kind of what the parameters are of that authorization. To go to your second question about where you keep it. So when I work with clients, we have people create them in sets of 3 originals. One that the client will keep themselves. Another one they oftentimes have their lawyer keep, because we've had situations where the family member will figure out this is the person's lawyer, but we don't have the documents, so the lawyer will keep it. And the third copy we have will go to the person that you appoint. So if you appoint somebody as the power of attorney, then they would have it. You can keep copies of it. I say to keep the original at home, unlocked in a file cabinet with like a big gold star on it. So if somebody's trying to find it, they can find it very easily. But you can keep copies at the safe deposit box. You don't really want your only original to be at the safe deposit box, because what if there's an emergency on a Saturday night at midnight? Banks aren't open then, so how do you access it? But I would also have another copy too that you've scanned in electronically and keep somewhere like, you know, Dropbox or Google Drive, something like that. And the cloud, but then to have a link to it and to keep it, on your phone where you have the emergency contact person, the ICE in case of emergency, have a link to it in there. So somebody finds it, they can know, okay, this person has it, and you can access it there.
Yeah, that was actually when you were first mentioning that. I think there is something on our phones that that I know the police and first responders can access. So I'd never thought to do that. That's really a good idea.
Absolutely. And, again, this is a multi-generational issue. It's not just for adults as individuals and then adults taking care of their older parents. It's also looking at the younger generation. So I'm a parent. I have 3 young kids. Every time I go away, if I leave my children with my parents for a trip, then I want to create a different kind of document. It's called a limited power of attorney. And it says if my kids need medical attention, then my parents who are taking care of my kids can seek that attention for them. If I don't have this document put in place, my parents would not be able to do that. My kids are frequent flyers at Inova Fairfax Hospital. So we want to make sure, God forbid there's a problem, my parents can do that. Same thing's true for a college student. If you have a child who is in kind of the 18 to 23-year-old range, if they're in college and they have a car accident or emergency surgery, even if they're on your health insurance, you have no rights to know what's going on or to be able to make any decisions or even to have information unless they have signed a power of attorney or an advanced medical directive before the incident arose. And I've seen a lot of parents who have no idea. Kids are traveling abroad, they're in college, and they're adults technically because they're over 18, but they still need a lot of help from mom and dad.
Yeah, this is actually something I had not really thought about because I have a son that's going to be a sophomore in college, and so it looks like I have some work to do.
A lot of people never think about it, and it's something that people say to me later on, that they have peace of mind, and that's what these documents are really about. We plan for the unexpected, and that's what these documents really are going to accomplish.
So I think probably one of the things that I encourage people to, when you talk about these broad brush strokes, especially going back to the medical, the advanced medical directive, are there particular things you would have people keep in mind beyond like life support, or because I'm thinking like if in the persistent vegetative state, so like what would be some key questions that could kind of get the conversation started?
Well, one of the big questions is about DNR, a do not resuscitate order. And that's always a very challenging topic. At what point would you want to enable a DNR, and at what point would you not? And that changes. If somebody has a terminal illness, they're going to look at it very differently than if it's somebody who is young and healthy and never had an issue with this. Mm-hmm. Questions about, especially for women with pregnancy, if you were pregnant, what would you want to have happen? Would you want the baby saved versus your own life, and kind of at what stage would that be? Questions about risky procedures, especially things like blood transfusions, or if there's tests that you would want to have, and who is it you authorize to do this? It's one of these things that I find a lot of people have had that conversation really late at night with their spouse, usually after they've watched something terrible on the news, but to actually take that and put it into writing. And the idea is that whoever you authorize, that person will put your best interests at heart. The person that you appoint, whether it's your spouse or your best friend or your sibling, does not have to be somebody who is a doctor or a nurse or a background in science. It's just somebody who says, this is what that person would want. It's not about what I want. It's about whoever you appoint. They saying that I'm putting your best interests at heart here. And that's going to be different for different people. But it's a conversation, and we want to have that, and to have that before.
And how often should we have the conversation?
I usually recommend to my clients to kind of look at their documents every 8 to 10 years. Things change. Sometimes if there's health issues going on, we'll look at it earlier, maybe every 3 to 5 years, especially if you are somebody who, if you have kids, if your child is 15 years old, they may need different kinds of documents. If you are, like the example for if I'm going away out of town and leaving the child with my parents, I have very different needs then versus if you have an 18-year-old to be able to handle that. So to have that conversation on a regular basis, and again, we frame it in the context of, I want to make sure, whether it's your teenage child or your older parent, that I can take care of you and help you.
Okay. So thank you very much, and thank you for joining us. We will be right back in a few minutes.
Staring contest.
test.
You still got it. I know.
Come alive with the forest. Visit discovertheforest.org to find a forest near you.
We're back to the Inside Scoop. Here again, your host.
So welcome back to the Inside Scoop. I'm your host, Melissa Batchelor-Murphy, and we're continuing our healthcare series talking about advanced care planning. And so we just talked a little bit about some of the legal aspects of advanced care planning, and Dr. Lynne Kennedy is here with me now. We're going to continue our conversation around some of the healthcare and health-related aspects of advanced care planning. And we have two tools that families can access and look at. One is called the 5 Wishes,
yes,
and then the other one is called the Pulsed. But in some states it's called the MOST, and basically it's either your medical orders for life-sustaining treatment or physician's orders for life-sustaining treatment. So which of those would you like to talk about?
Well, we should talk about 5 Wishes first, because it's written in easy to understand English, not in legal format, and it's translated into so many languages that it makes it easy for people, even if they can speak English extremely well, when it comes to making a decision that's so important to how you want to be cared for near the end of life, it's important that you really understand what it says. So you need to see it in your own language. And that's why it's one of my favorite forms, because it has been translated into so many different formats.
Yeah, 27, and then you told me
in Braille as well, yeah.
Which is great. And so the 5 questions, again, go back to the, it's kind of beginning to have this conversation,
yes,
and kind of helping you frame the conversation so that you can have it with your family and your healthcare team. I think the 5 questions are: who's the person I want to make care decisions
yes,
when I can't? What type of medical treatment do I want or not want? How comfortable do you want to be? How do you want people to treat you? And then other things that you want your loved one to know. So is this a form that you give to people?
We never just hand it to people. What we do is we ask them if they would like to have a discussion about making some plans, and we bring one of them in and we let them look at it in their most comfortable language, and we go through a conversation with them. I always say I never give somebody a 5 Wishes form that isn't also attached to a warm body, because it's very important that they get a little bit of guidance just to get them started thinking along the right way. Like, you can put something in there about listening to Tchaikovsky, about having somebody telling jokes, or you wanted to talk about some other interest that you have, or talk about games that you played when you were in university. It doesn't matter what it is that you want to do, what you want to reflect on. But if you don't get it down in writing, nobody's going to know. So it's not just about medications that you're going to take or treatments that you're going to take. It becomes very personal. And it can also be attached to doing some legacy work, and it gives us a chance to bring that up to people. Well, I really want you to keep me alive no matter what until after my granddaughter is born. She's going to be here in 2 more months, but she'll never know me. Well, being there to see her is very nice, and we can try to fulfill the wishes, but if we do some legacy work, she really will know you.
Right. And I think it's really a chance for people to communicate about what it is that you want them to remember about you, and also sharing things that you remember.
Yes, absolutely. And a lot of times when you're starting to do legacy work and you bring your children in and your other family members, they'll say, I didn't know that about you. That's so interesting. Why didn't we ever talk this way? And frankly, it's just difficult to talk this way. But once you've opened the door, it's like a floodgate. All of a sudden, people are actually talking about their innermost thoughts. And I frequently end up giving out a couple of extra 5 wishes forms for the people who are the POAs. I should really have one of those now. And hallelujah, so we're getting somewhere. People are starting to see that it's necessary. And there really are consequences to lack of planning. When people are surveyed, they say, 90% of them say, I want to be home, I want to be comfortable in bed with my friends and family around, I want to be talking to them. Only 20% of those people get that wish. Mm-hmm. And it's because they don't name a POA, that's a power of attorney. They don't tell the POA that they are the POA. They don't make them aware of what their wishes are. And if you don't share your wishes with somebody, they may go through years of crisis trying to figure out, did I do too much and make mom suffer at the end? Did I not do enough? Should I have done more? This takes that away from them. It gives you control, and it makes it easy for your family members. It truly is a gift to be able to give somebody your decisions and why it's so important to you.
Right. I think families, when they understand kind of the rationale behind your decisions, it helps them make future decisions.
Yes.
And the MOST form is recognized in the state of Virginia as a living will, and on their website it's called the Living Will with Heart and Soul. But you can download this and, you know, read through it. I think the charge was like $5, but then you can also do one online.
Yes, you can.
And then to be sure that after you've completed it, that you then use it to talk and share it with other people. You can't just write it down here and hide it away.
And you need to know where it is. Putting it in a safe deposit box is not right. Give a copy to the person who's the POA. Put it somewhere in your kitchen that's easily accessible. Give a copy to your doctor. If you've been in a hospital and have an electronic medical record, have them scan that into the electronic medical record.
Yeah. I mean, because it's not only a gift to families, it's a gift to providers too.
Absolutely. They know, now they know exactly what you want and what you don't want and what you consider good care. This is very important. Because otherwise they will be fumbling around trying to figure out, well, what should I do? It's not like somebody being wheeled into the emergency department and a doctor sticks his head in and says, do you want me to do everything for you? Well, who's going to say no? Yeah. But if you explain what everything is, you may not want everything.
Exactly. So I think we'll use that to kind of segue into the physician's order for life-sustaining treatment. This is something in like the late 90s kind of began to have movement and gain traction.
It did. It's taken a long time, and it was started in Oregon and West Virginia are the 2 strongest programs in the country. There are many others now. We were the 19th endorsed state.
Yeah,
there's now 44.
In North Carolina, it's called the MOST form.
And in New York State as well, it's called MOST. We are POST, and West Virginia is also POST, and then there's Louisiana is La Post, and one of the other states is TPOP, and I don't know where that came from.
Yeah, well, they want it to be different.
Yeah, so there are a lot of different names, but the wording is very similar on all of them, and the reason that they're there is from a similar perspective. And we all conform. We talk to each other. In Virginia, we actually teach courses so that facilitators learn how to have a conversation with people.
Yes, and I think one of the things that was mentioned in the last segment was a DNR, but a DNR is not a legal document. It is a healthcare planning document. But
correct.
Maybe explain how the POST form or the PULSE, whatever we call it, whatever it's called, how it's more expansive and how
it's much more expansive because there is a form called a DNR, and then out in the community it's called a DDNR. It's a durable DNR, but that's only about compressions. It's only about having CPR done. There's a lot more healthcare to your prognosis than just compressions. Do you want comfort measures? Well, we give comfort measures to everybody, but maybe you want more. Do you want to be intubated? Do you not want to be intubated?
Right.
Do you want to put a time trial?
The intubation is when they put the breathing tube down,
That's
and you're
correct.
basically put on life.
You're
that's
on
what's
a
considered
machine.
life support.
Yes.
And I think another important point to make at that, with that in mind, is that it is much easier to decide not to have to be put on that or intubated. Right. Much easier to make that decision ahead of time than afterwards, and be the one who says, well, then I had to make the decision
to turn it off.
Right.
Yes.
And it's the same thing with feeding tubes.
And it's a terrible thing to do to people, to put them in that position where they have to think about it. So if you do want to have heroic or aggressive measures done, put a time limit on it. Because if we are able to make positive inroads in your care, it will usually begin within 72 hours.
Yeah. And the great part about this form, and I will put a link to it up on my website, is that you can decide between full treatment, selective treatment, or comfort-focused treatment. So it's really those three areas that go beyond the CPR, and then it gets into kind of artificial hydration and nutrition, which goes back to the IV therapy that you were talking about, and even the feeding tubes, which is my research focus. So at what point would the most form, I think, should be as soon as you turn 18, and they also have a young child version and an adolescent version of the most form.
Yes.
So everybody needs to be doing the 5 wishes, but when does the post form come into play?
The post form is physician's orders, and that is meant to carry your advance directive into medical translation. It's designed so that it will happen. It is now not just your wish, it's a doctor's order. This is the care that she has said she wanted, and this is the care that she is going to get. It's meant for reasonably the last 12 months of life.
And it goes with people across settings?
It does go with people across settings. This particular form is good anywhere in Virginia, but other states that have the post format will be able to honor it and translate it into their own form if you happen to be out of state.
So thank you for joining us this evening, and this is all meant to just help the transition between here and the ever after. So you can check my website, melissabphd.com, for more.